We have four speakers today. I'm going to first of all present some information about benzos, dependence, and withdrawal. It'll be very high level because the other speakers are going to go into a lot more detail. First up will be John Staight, who'll provide inside the struggle, a tapering journey from somebody with lived experience. We will go on to Nicole Lamberson, who actually also has lived experience. She'll be talking on tolerance, detox, protracted withdrawal syndromes. And we'll close out today with Dr. Alexis Ritvo, Benzodiazepines and the Hidden Prescription Epidemic. For anybody who has questions during any of these presentations, please feel free to put them into the chat room. Jamie will collect them and we'll try to address them as much as we have time for at the end of all the presentations. So again, I just want to thank everybody for joining us. This is great. We're so excited to have you here. So let's get going. So my name is Dee Foster. I'm co-chair of the Benzodiazepine Action Work Group. You can go to the next one. I'm also the host of the Benzo Free podcast, author of the book Benzo Free, and I myself are lived experience. So I've dealt with clonazepam withdrawal I was on it for 12 years, tapered for 18 months, and I'm now 7 years benzo free, but I still have protracted symptoms. It was the hardest experience of my life to go through it, and I lost my job and I lost several other aspects of my life. But good news is I've come out of it and I now do this and I love this. So if you want to know more about what I do and we do in our organization, please visit us at easinganxiety.com. Next slide. Let's talk a bit about benzos. This is going to, like I said, be very basic. And if you already know this, trust me, it'll go quickly and we'll get into more depth. Benzodiazepines are a class of psychoactive medications, also known as benzos, BZDs, BZRAs, anti-anxiety drugs, minor tranquilizers. They're used to treat anxiety, insomnia, muscle spasms, and many other conditions, as most of us know. At about 66 million doctor's appointments a year, a benzodiazepine is prescribed. And 90% of all benzodiazepines are being prescribed by primary care providers. Benzodiazepines come in many flavors. There's 30 or 40, I think 40 plus different specific benzodiazepines, often going by the brand names of Xanax, Klonopin, Valium, Ativan, Restoril. We also include in this group, and we often talk about non-benzodiazepines or Z drugs. Reason we include those is even though they have a completely different chemical structure to benzodiazepines, they often have similar effects when it comes to dependence and withdrawal. So especially when we use the term BZRAs or BZRAs, we're often talking about both these groups. So just so you know, if you are somebody who has taken those drugs or know somebody who has, we often are dealing with both when we talk about benzos. Next slide. Benzodiazepines vary by potency, speed of effectiveness, speed of elimination or half-life, and focus of treatment. And the reason this is important to keep in mind is this can really affect people who are trying to come off the drugs or taper. Potency and half-life can be big factors in that process. And also the symptomatology we've learned can vary based on the different brands. Next slide. There we go. But we're going to talk a bit about the hidden epidemic. Benzodiazepines have been prescribed for over 60 years. Librium came out in 1960. Valium came out in 1969. Xanax in 81. They keep coming out with new brands. And every decade, serious concerns were raised about long-term consequences. As you can see here, the quote from Edward Kennedy when he spoke in front of the Senate subcommittee hearing in 1979. But unfortunately, little lasting change happened. And there are two areas of concern that we look at, and one is street use and overdose. Of course, especially with the consortium dealing with prescription drug abuse prevention, we talk about that a lot. And a lot of times, benzos can be used in conjunction with opioids. In fact, 33% of all opioid deaths in 2017 included a benzodiazepine. But the other side is long-term effects, and we deal with and we start to approach that. We start to look at that as the hidden epidemic, because this is the one that a lot of people don't talk about. Next slide. Some people do withdraw from long-term benzo use with little or no problem, and that is great. And we are really excited that some people can do that. But for other people, this experience can be ineffable. It can be a real life-altering experience. The severity is often underestimated. The duration is often underestimated. It can last months, even years for withdrawal from these drugs. Life effects that happen on people from career, family, relationships, all types of life effects happen from these drugs. This is a major event for some people in their lives. And honestly, the suicide rate is also high, and it can be also another factor. So this is a significant event for many people. We broke down the symptoms within benzodiazepine, there's over 100 symptoms that have been identified that have been related to benzodiazepine withdrawal. We broke them down to psychological symptoms and physical symptoms, a total of 12 categories. This is based off of the Ashton Manual created by Professor C. Heather Ashton. If you haven't checked that out and you want to know more, it's a great resource to go to. But as you can see, we kind of broke it down into 12 basic categories of symptoms. I'm not going to go into a lot of detail. Some of my speakers after me will talk more about that. Next slide. One thing I do want to hit on, of course, is addiction and benzos. As far as the consortium goes, I know we deal a lot with addiction, but when it comes to benzodiazepines, addiction exists, but it's rare. And often when it is, it's often combined with opioid use or other prescription medication. Physical dependence is more common, especially for people who have taken them as prescribed. Most of the people I support through the podcast, most of the people these other organizations support, are dealing with people who have taken them as prescribed. Why is this important? Number one, treatment differs. Most people coming off of benzos, they find the most advisable method is a slow withdrawal taper, sometimes even lasting months or years for them to taper off their drugs. And that abrupt cessation, going cold turkey, can be very dangerous, and it's something to always be careful of. It can even be fatal in some cases. Also, the methods differ between addiction and dependence as far as terminology and various protocols. And of course, the length of recovery for people from benzodiazepine can last years, often longer than some of the other medications. Most long-term benzodiazepine users find themselves isolated and afraid with nowhere to turn for help. These are the people I deal with daily, and I know other people who are going to be speaking here have also been working with them daily, and their stories are just heartbreaking. We're trying to help change that. The Benzodiazepine Action Work Group, BAWG, which I'm co-chair along with Dr. Alexis Ritvo of, our mission is to increase benzodiazepine safety through education, patient support, and informed prescribing and deprescribing practices. We are part of the Colorado Consortium for Prescription Drug Abuse Prevention. You can go on to the next slide there. And our membership includes medical and mental health professionals, community support leaders, and benzo community organizers. We have groups, representatives from groups like the Alliance for Benzodiazepine Best Practices, Benzodiazepine Information Coalition, the Schreiber Research Group, and many others that are members of this group and are working hard to make some lasting change. We do have a Colorado focus because we are Colorado-based and some of our funding comes from Colorado specific, but we also have a national reach. Our group is trying to make changes through incubation type of programs and pilot programs that can carry on outside of Colorado too and become national and international focused programs. Two new things we have going on. One is a speakers bureau. We have created a speakers bureau within the Benzodiazepine Action Work Group. Several members have volunteered to be speakers and have experience being speakers, both medical professionals and people with lived experience. So if anybody's interested in having speakers, please reach out to us. We'll have some documentation on that on the website, probably by the end of next month. And the second thing is we have some new online documentation. We have prescribing, deprescribing, and peer support documentation that we've been working on for about a year now, finally posted on our website. So if you go to corxconsortium.org, click on work groups and go down to the benzodiazepine work group, you can see some of these documents, and I hope you go check them out. And that's going to close it out for my presentation. I told you mine would be quick, and we are going to move on to the next person. Nicole is a physician assistant residing in Virginia. She practiced in an urgent care and occupational medical setting until severe illness from benzodiazepine withdrawal syndrome left her unable to work. Nicole writes about benzodiazepines and their potential to cause severe and/or protracted withdrawal syndromes, and volunteers her time helping with ongoing benzodiazepine awareness initiatives. She serves on the medical advisory board of Benzodiazepine Information Coalition, and she is a founding member of the Colorado Consortium's Benzodiazepine Action Work Group. Nicole has also co-founded the Withdrawal Project, and she does marketing, distribution, and outreach for Medicating Normal, the film. She hopes to continue to use her lived experience to advocate for more education and awareness around benzodiazepine risks and harms, as well as changes in prescribing and withdrawal practices. So let's hear from Nicole. Nicole, you're on.
Can everybody hear me okay?
Yes, you sound clear.
Okay, great. Hi everybody. My name is Nicole Lamberson, and Dee, thank you so much for the introduction. So we can go to the presentation objectives slide. In this presentation, I'm going to talk about my personal testimony of benzodiazepine injury. That's often referred to as iatrogenic harm, meaning it was caused by medical treatment. I took benzodiazepines as prescribed. And I developed benzodiazepine-induced brain injury, which is what this discussion today is about. I'm going to define benzodiazepine tolerance and talk about why it's important to recognize. And I'm going to discuss over-rapid withdrawal and detox from benzodiazepines because I experienced that myself. And then lastly, I'm going to talk about protracted withdrawal syndromes and why they're important to recognize. So next slide. First, a little about my story. In the early 2000s, I was prescribed Xanax for work-related stress. I was started on what would be considered a low dose by most medical providers and probably patients too, about 0.5 milligram or so as needed. I say would be considered a low dose because, as I've discovered over my many years being in the benzodiazepine withdrawal support groups and suffering from benzodiazepine injury myself, that this drug class can cause issues at seemingly small doses as well as large ones, and in a relatively short amount of time, as short as 1 to 2 weeks for some people. For others, it takes much longer to cause issues. So for me, tolerance developed quickly, although I didn't know that that is what I was experiencing. And I'll define and discuss tolerance in more detail on my next slide. The adverse symptoms that I developed from benzodiazepines were misdiagnosed. I was told that I was having a worsening so-called mental illness. And I subsequently entered the psychiatric system, where I would remain for almost half a decade before figuring out that benzodiazepines were making me ill. During that 5 years as a psychiatric patient, I was subjected to a prescribing cascade and polypharmacy, which I'll also discuss more in subsequent slides. But essentially, I was put on a lot of other psychiatric medications because of the harm that benzodiazepines were causing me. I wound up on 6 drugs in total, 2 benzodiazepines, so the Xanax, which was the initial drug, Klonopin. I was put on a sleeping pill, Ambien, which is a Z drug, Adderall, Seroquel, and Remeron were my 6 medications by the end. In my 5 years of being drugged with benzodiazepines and seeing countless specialists, not one medical provider in that time ever mentioned that benzodiazepines could be the cause of any of the symptoms I was experiencing. I had to discover what was wrong with me. First, because a family member, my father, who is a physician, noticed changes in my health and personality. I also stumbled across a magazine article by another benzo injured patient who wrote about his injury from benzodiazepines and put it in a magazine. And I found the magazine article. And then eventually I found more on the internet. There are large and numerous underground communities online of people harmed by this drug class. And they're all supporting and helping one another to withdraw because they struggle to find validation, correct diagnosis, and support from their medical providers. Sadly, I didn't find the online support communities or the Ashton Manual, which is a very valuable guide by a British benzodiazepine expert psychopharmacologist. I didn't find those things soon enough, so I followed, unfortunately, more bad medical guidance to go to an inpatient detox center. There, the doctors, addiction psychiatrists rapidly removed me from any drugs they deemed addictive. And this was in spite of my history of regular psychiatric care and follow-up. and taking the medications as prescribed. So they did a standard detox protocol there, which is pretty typically like a week of phenobarbital, and then they add in gabapentin. I was put on 900 to 1200 milligrams of gabapentin, which is actually another drug class that can cause physical dependence and withdrawal syndromes. They kept me on the Seroquel and Remeron, and then they also tried adding even more psychotropic agents there, like trazodone and Effexor. I assume attempting to cover up the withdrawal syndrome that was emerging from the benzodiazepines, although those drugs didn't cover the withdrawal at all. So that detox center may have written me down as a success story. I don't know. I was discharged home and became very ill, and I never returned to the center. So perhaps they think they succeeded, when in fact it caused terrible harm. I developed severe withdrawal, which I'll discuss more in the presentation. So I detoxed in 2010, and although I had a short reinstatement period by an outpatient psychiatrist in an attempt to stop the severe and intolerable withdrawal that was brought on by the detox, I tapered off of that, reinstated benzodiazepines for about 18 months. So I still suffer symptoms today. I'm about 9 years after my last benzodiazepine exposure and 11 years after the original detox. So I was just saying, even with the privilege I possessed of being a physician assistant and having a father who was a physician who accompanied me to most of my appointments, I was met with disbelief and ignorance about benzodiazepines and their potential to cause harm by every clinician that I encountered for the most part. I did get lucky and find one psychiatrist who didn't know a lot about it, but she was willing to learn. Most treated me through an erroneous addiction lens, and I was and still am disbelieved and invalidated about the severity and duration of what I experienced. Next slide, please. So tolerance. Tolerance to many of the effects of benzodiazepines develops with regular use. In the introduction, Dee Foster talked about prescribed physical dependence. Basically, chronic exposure to benzodiazepines causes changes in the body and brain due to the presence of the drug. And tolerance usually means that someone has developed physical or physiological dependence to benzodiazepines. So the body responds to the continued presence of the drug with a series of adjustments that tend to overcome the drug's effects. The original dose of the drug has progressively less effect, and a higher dose is often required to obtain the original effect. And doctors will sometimes increase the dosage or add another benzodiazepine. Some patients end up taking two at once, which was the case in my story. I wound up on Xanax and Klonopin and Ambien. And interdose withdrawal is also a function of tolerance, where withdrawal symptoms start to develop while the patient is still on the medication and often in between scheduled doses. For reasons yet unknown, not everyone seems to develop tolerance, and people will develop it at different rates. Some develop quickly and others can take years. Next slide. So some classic tolerance symptoms are insomnia and sleep disturbances, anxiety and panic, cognitive decline, memory loss, and agoraphobia. In Dr. Heather Ashton's benzodiazepine clinic, 10 out of 50 patients became agoraphobic for the first time while taking benzodiazepines. I became agoraphobic myself in tolerance while taking benzodiazepines. I never had anything like that prior in my life. I developed extreme anxiety that I had never had before. And this is why prescribing benzodiazepines regularly and long-term for the majority of patients with anxiety and insomnia is ill-advised and quite frankly makes not a lot of sense, because when tolerance develops, anxiety and insomnia can actually worsen and become more severe than they were initially or ever before. And that's due to the benzodiazepine itself. So to minimize this risk, benzodiazepines are most effective when used rarely and intermittently, like one-off doses for flight anxiety or the dentist. Ultimately, in my tolerance, I developed insomnia as well. I started to struggle to function at work. I had to write everything down. I couldn't remember things, and I became completely overwhelmed trying to learn new things. Next slide. Some of the other many symptoms I experienced during tolerance: lots of GI symptoms. I had rashes, joint pains, depression. I became suicidal. I was sleeping constantly, fatigue, no motivation. I isolated from friends and family. I was agitated constantly, could not handle stress. I had rage, screaming fits, which were completely out of, my personality, obsessing and compulsive behaviors, racing thoughts, paranoia. Next slide. So why is tolerance important to recognize? Because like I mentioned earlier, prescribing cascade and polypharmacy oftentimes result when tolerance is not recognized. The tolerance and interdose withdrawal are often misdiagnosed as the patient's condition worsening or a new underlying condition. And so more and more medications are prescribed. Like I said, I wound up on 6 medications. And then the prescribing cascade is really one drug to sort of treat the side effects of another. So Klonopin was added when Xanax tolerance happened. And then when I was so tired and depressed from benzodiazepines, I was put on Adderall to keep me awake and focused and to help with depression. When Adderall suppressed my appetite, I was given Remeron so that I would eat again. When I stopped sleeping, Ambien and Seroquel were added at bedtime. Next slide. Then you get into tolerance being important to recognize because of something called medication spellbinding. Basically, this happens so insidiously with benzodiazepines for some people that they don't recognize, the patient who's taking the benzodiazepines don't recognize that the benzodiazepine is their problem. So they often underestimate how impaired they are. They deny the harmful role that the drug might be playing in their altered state. Sometimes they even think they're functioning better. And 2 things that might reinforce that is that if you are someone who strongly believes in conventional medicine, like I did, I was trained in it. So I had this feeling and thought that doctors cure and they don't ever, cause harm. And so why would my doctor give me a medication that was harming me? And then also every time I went back to the doctor, I was told that, oh, this is your so-called mental illness, your underlying conditioning is worsening, this is proof that you actually need the medications. So all of those things reinforced me not figuring out the benzodiazepines were my problem. And lastly, tolerance is important to recognize because lots of people spend countless years and lots of money and tons of misery chasing diagnoses and getting treatments they don't need, paying for harmful and even useless medications and therapists. And really, it's their altered physiology from the benzodiazepines that is the problem. Next slide. So, like I said, I had a detox or over rapid withdrawal. This is inappropriate for patients who are not suffering from addiction. In other words, patients who were prescribed benzodiazepines and who are taking them as such. Often, it's also important to note that if a patient reports feeling that they need to increase their benzodiazepines, it may just be because they are having tolerance or interdose. That doesn't mean that they are addicted or suffering from addiction. These patients who are subjected to detox are harmed twice. First, by the long-term prescription, usually without adequate informed consent, and second, by this medical mismanagement. Detox can result in severe withdrawal syndromes like seizures, psychosis, akathisia, which is a severe movement disorder that can cause suicide, and even death. Detoxes often fail. The patients can do poorly. Like in my situation, I actually wound up back on benzodiazepines because the withdrawal syndrome was so severe I couldn't endure the detox. a lot of times you'll pay thousands of dollars to go to these centers as well. So it's very expensive. You wind up on more polypharmacy at some of the detox centers. And if your family and friends think that you are suffering from addiction, a lot of times they will give you, tough love, or they will say, the addiction model is not to enable the person, when actually patients who are suffering from benzodiazepine problems need a lot of support. Next slide. So protracted withdrawal syndromes. Studies report that 10 to 44% of chronic benzodiazepine users experience moderate to severe protracted withdrawal symptoms upon cessation, and the protracted withdrawal can last months or years. Some potential risk factors are cold turkey, rapid tapers, genetics, and kindling. We're not actually sure why people get protracted, and even some folks who taper slowly will go on to get protracted syndromes. There is a problem for some people with the nomenclature. Protracted describes the time sequence of how long things can take, but the term withdrawal can be misleading. So, for example, in my case, I haven't been withdrawing from anything for 9 years. So I don't feel like this is withdrawal, but I still have symptoms. So some have suggested calling this phenomenon benzodiazepine-induced brain injury or benzodiazepine injury syndrome. Other suggestions are neurotoxicity. Next slide. So some of my protracted symptoms are depersonalization and derealization, like being detached from myself and my surroundings, neuropathy, burning skin, inability to multitask or endure stress, anxiety, irrational fear and paranoia, irritability, chronic fatigue, anhedonia and flatness, numbness. Next slide. Dizziness and off balance and constantly feeling like I'm moving on a boat, vision problems, headaches, muscle spasms, nausea, cognitive impairment, a meningitis or concussion-like feeling, like I've been, just kicked in the head, feeling like a switch has flipped in my brain, that if it would just turn back on, I could connect again, but it won't. Insomnia and adverse reactions to medications, which is hypothesized to be due to the hypersensitivity of the nervous system. Next slide. So as Dee touched on initially in his intro, the impact of being in protracted withdrawal is huge. I have lost my job and been unable to work, which has massive financial implications, both short and long term. This has had a horrible impact on relationships. I was a woman of childbearing age at the time of prescription, and so I haven't been able to have a family because I've been ill during that time period. So this is something for patients and clinicians alike to consider. Lost life experiences, just feeling like I've been in a coma for over a decade. And even if you do eventually get better, you've got, in my situation, 10 years of being ill. So you're left to sort of clean up the mess, and lots of trauma, especially medical trauma. And some people develop PTSD from the experience. Next slide. So why is recognizing protracted syndromes important? Patients need support and validation and hope. Some people do take their lives because this goes on for so long and is so severe. Clinicians, please keep protracted withdrawal in your differential. That way you can avoid more misdiagnosis and more mistreatment. Otherwise, for people experiencing it, it's hard to go to the doctor, because when you bring this up, if they don't consider it or believe it, then you're just chasing all of these new diagnoses. Lastly, we need more research into what causes protracted withdrawal and how to reduce the risk of developing it, treatments and how to best help these patients, what percentage of people who develop protracted withdrawal will recover, and will there be permanent symptoms. And final thoughts, I don't want to sound dramatic, but it's true. I consider taking benzodiazepines the biggest mistake and regret of my life, and the worst thing that's ever happened to me. And the withdrawal and protracted syndromes that result from long-term use in some patients can be severe and cause suffering that is indescribable. There are many times throughout this 10-year ordeal that I thought about dying because it seemed like it was the only way out. And so as a result, the decision to start for patients and clinicians and stop benzodiazepines should not be taken lightly at all. Thank you very much.
Thank you very much, Nicole. That was great. We're going to go ahead and move on to Dr. Alexis Ritvo, and then we'll try to loop back to John once we get a chance. We're still working in the background trying to get him a good connection, so we'll see what we can do. Alexis Ritvo is a board-certified addiction psychiatrist. She is the program director for the Addiction Psychiatry Fellowship at the University of Colorado School of Medicine, where she is an assistant professor of psychiatry. She also has a master's in public health and health policy and has a passion for psychotherapy, teaching, and improving health systems and policies. While the majority of patients using benzodiazepines have taken them as prescribed and do not have a benzodiazepine use disorder, in other words, an addiction, most patients that take the benzodiazepines regularly beyond 2 to 4 weeks will develop physical dependence. Alexis recognizes that addiction specialists can adapt their knowledge of treating physical dependence and withdrawal in addiction to help patients on benzodiazepines. Dr. Ritvo, it's all yours.
Thank you so much, Dee. So thank you for being here today. And next slide. So a few things I'll try to cover very briefly today, but just increase your knowledge about potential harms for prescription benzodiazepines, describe withdrawal, protracted withdrawal, and benzodiazepine-induced neurological injury, although that largely comes from my peers and colleagues, Nicole and John, and then increase some knowledge about safer deprescribing, also known as tapering of benzodiazepines. I know some people are saying they're just a real quick housekeeping, distracted by the chat. You can mute it if it's if the questions and information's bothering you. So next slide, please. So short versus long-term benzodiazepine use. So overall, long-term benzodiazepine use begins with the treatment usually of acute distress. That might be anxiety, insomnia are the most common reasons, or just overall people feeling overwhelmed, stressed out. The information we have from studies of benzodiazepines is that they're relatively safe for short-term use, 2 to 4 weeks, but studies really have not established their safety beyond that period. Recommendations are really that you try to limit the initial use to 2 to 3 weeks at most while starting other interventions. So for anxiety, some of our best treatments are the antidepressants, the selective serotonin reuptake inhibitors and the selective norepinephrine reuptake inhibitors. But also there's a lot of good behavioral and other therapeutic interventions that can be done that don't require medication. Next slide. So unfortunately, our rise of prescribing benzodiazepines, it just keeps going up and up. And some have referred to benzodiazepines as the next prescription epidemic. One study from 2003 to 2015, the percentage of outpatient medical visits where benzodiazepine was prescribed doubled. And half of those are occurring in with primary care. And that's not surprising. Primary care sees a lot of patients for a myriad of reasons, and they have very limited time with the patients and often feel pressured to provide some sort of answer or intervention on a short-term basis. Next slide. Unfortunately, other studies have also shown that once a benzo is prescribed, it's likely to be continued. So, most primary care providers are going to have 15 minutes at most with a patient, give a script for at least an initial 30 days because it's hard to get someone back in sooner. And then by that point, you're at the 4-week mark. And as you can see, so the dark bar is folks presenting to a physician and getting a new prescription for a benzodiazepine. And the kind of rose or lighter color pink bar is individuals that are presenting and getting a prescription for a benzodiazepine, and it's being continued. So once benzodiazepines are prescribed, they're largely continued. And that's because for a lot of people, they're initially quite effective in making people feel less anxious or being able to sleep, but they are often not given proper informed consent about how these medications work and what happens when you take them beyond that initial period, and also that even in the initial period, there are certain risks that come with them. Next slide. So about just over a year ago, the FDA finally added or updated the black box warning for benzodiazepines. Unfortunately, I worry that not majority of prescribers of benzodiazepines may not even be aware that this happened, despite the fact they really should. Two things that this black box warning added. So they said the current prescribing information for benzodiazepines does not provide adequate warnings about the serious risks and harms associated with these medicines, so they may be prescribed and used inappropriately. And the other part that I think was extremely important, there's much more to this warning, but was physical dependence can occur when benzodiazepines are taken steadily for several days to weeks, even as prescribed. Stopping them abruptly or reducing the dosage too quickly can result in withdrawal reactions, including seizures, which can be life-threatening. To me, those sentences should be provided to every single patient whenever even considering starting a benzodiazepine. Next slide. So there, as Nicole already alluded or provided a list of for her unfortunate personal experience, there are a myriad of benzodiazepine-related harms, both that can occur when taking a benzodiazepine as prescribed, as well as when stopping a benzodiazepine. Some of them include increased suicidality and self-injurious behavior. This increases 2 to 4-fold when controlling for other risk factors for that behavior. Pulmonary conditions, so benzodiazepines affect your respiratory drive. So if you already have a condition that decreases your ability to breathe properly and get enough oxygen, like COPD or obstructive sleep apnea, benzodiazepines can make that worse. With increased age, we know there's increased risk of falls, especially leading to hip fractures, delirium, which is kind of a waxing and waning confusion, lack of orientation to where you are, what's happening, and overall cognitive impairment. So difficulty with short-term memory, attention. And these things can happen even before people get older, but as you age and your brain ages, that risk continues to increase. And then there's this phenomenon of interdose withdrawal and rebound anxiety, insomnia. And I think as Nicole described so well, it gets missed as, oh, you must just need more medication, and not realizing, oh, like this is because the medication's wearing off between doses, and you have the physical dependence, and so you're starting to feel the withdrawal from it, or that actually it's not that you have more anxiety, insomnia that we were originally treated, but now we've created more because you're getting withdrawal from the medication, and that creates the withdrawal itself creates anxiety and insomnia. And then I think if another really important part to drive home is, for the vast majority of individuals prescribed benzodiazepines, while they will develop physical dependence is not addiction. And very small percentage of individuals that take a prescribed benzodiazepine develop or have addiction or substance use disorder to the benzodiazepines. So 2% of individuals that are prescribed a benzodiazepine will develop a use disorder to it, and 17% will at least from one study, misuse, as far as ending up using it more than they should, or for reasons other than prescribed, or not taking it as prescribed. Next slide. So again, if this is one of the few things I can drive home, we need patients to know that anytime you take this medication regularly beyond a few weeks, you will develop tolerance. So you'll need more to get the same effect, and the potential for withdrawal if you cut back too quickly or abruptly stopped. And that is expected with regular use of a prescription, and by itself is not addiction. Addiction, so a substance use disorder, in this case for benzodiazepines, they fall in a class called sedative hypnotic use disorder, must also come with these other components. So one way I think of it very roughly is the other criteria fall within 3 C's. So you have to develop a loss of control of your use, consequences from your use, which means it's negatively impacting your relationships, your work, your recreational activities, your psychological health or your physical health, and you're continuing to use, and craving, so a strong urge, desire to use. So you must have some component of those other things along with physical dependence to have an addiction, but physical dependence is expected with regular prescribed use. Continue. So this is just the information I've kind of already given, but in a visual format. So again, research suggests, and this is coming from the National Institute of Drug Abuse, so a very reputable source, that benzodiazepine use is high, but use disorder rates are low. So, 12.5% of US adults per this survey were taking prescribed benzodiazepines. And as you can see, 17% of those prescribed benzos misuse, and 2% end up with a use disorder. Next. So risks of chronic use and abrupt cessation. So I'm presenting 3 patients I have seen de-identified, but just to give an idea of, so just to clarify, so I'm an addiction psychiatrist, but I work in a general outpatient psychiatry clinic where where I mostly supervise psychiatry residents, and we're mostly seeing kind of patients that present to general psychiatry for a myriad of reasons. And many of these, when it comes to benzodiazepines, started on by primary care, who's of course trying to help these patients out with the limited time and resources they have. And then when that doesn't end up helping the initial issue or other issues emerge, like then they end up showing up to us and trying to figure out what else to do. So one patient that had been on clonazepam, also known as Klonopin, 1 milligram daily for anxiety and agitation. That's not a particularly high dose, but clonazepam is a particularly potent benzodiazepine. So over the course of 2 years, they experienced worsening cognitive impairment, worsening memory, attention, ability to focus. On one of our formal screens was screening positive for having kind of a moderate to severe cognitive impairment, and we were referring to neurology for further workup, concerned that maybe this was an earlier onset dementia or something else. However, we were finally able to slowly taper them off of clonazepam, and actually within several months of doing that, their cognitive impairment completely reversed. Another one on patient on clonazepam, 1 milligram twice daily for 10 years, that had been started for anxiety in the setting of having multiple other medical issues, including a kind of progressive neurological disorder. And they really struggled over that 10 years with significant irritability. And that irritability, they ended up realizing only when they accidentally were stopped on their benzodiazepine due to a prescription issue they experienced, which is dangerous and should not happen and put them at risk for even protracted withdrawal. But after that, luckily for them, that resolved within a few months. But then, and their irritability actually several months later went away. And they keep saying, like, I can't believe for a whole decade I was so like irritable and horrible with my family, and I have to repair these relationships, and it was due to this medication. And then finally, another patient that was on lorazepam, also known as Ativan, 1 milligram nightly for 5 years. Another prescription issue, got sent to the wrong pharmacy out of state or something like that, and or somewhere else in the state. They ran out. They experienced severe acute withdrawal. insomnia, anxiety, agitation, restlessness to the point family members were worried they might be manic, presented multiple times a day. And when they described what was happening to primary care, I think primary care felt overwhelmed with what was happening, and rather than feeling unable to address it, just said, you have to find a psychiatrist to help you with this. Next slide. So I know we're kind of running short on time, so I won't I guess go too much into this because Nicole mentioned a lot, but I think overall we need to know that most patients will experience some sort of withdrawal symptom if they've been taking a benzo regularly, really after that, like 2 to 4 weeks. But one study back in 1990 even said, like, once they've been taking it regularly for a year, somewhere 58 to 100%. And a lot of times, again, these withdrawal symptoms get misidentified or attributed to other things. Same numbers that Nicole used, but 10 to 44% will have this protracted withdrawal. But again, we're kind of thinking, we might need to rename this like a benzodiazepine-induced neurological injury, because many of this withdrawal symptoms persist long beyond taking the medication. And I think always remembering prescriber and the patient are on the same team, and that's the patient's team. And it's a marathon and not a sprint to get someone off, or even getting someone on a lower dose decreases some of the risks of taking these meds long term. We need to go slowly and cautiously. And remember, for some patients, the risk or the and destabilizing effect of tapering may not be worth trying to get them completely off. Next slide. And so the last thing, just kind of pointing out, there's also this additional really acute risk of co-prescribing benzodiazepines with opioids because of the risk of unintentional overdose. And as you can see, this has really increased over time. And 35% of patients receiving a benzodiazepine script had a co-prescription for an opioid. Next slide. And overdose deaths involving benzos has only gone up. So 35% have an opioid, about 30% of overdose deaths with an opioid include a benzodiazepine. Next slide. And so some things I really think all prescribers need to know and be telling their patients is the increased risk of overdose when combining those two. Is for the first 90 days that you have a concurrent prescription of an opioid and benzo, your risk goes up 5-fold. So whenever I see those on their prescription drug monitor, I tell patients I automatically prescribe naloxone and want them to know how to use it, and family members want it to be somewhere. And that has been a good starting conversation for some patients about trying to decide if maybe trying to taper or get off one or both of those medications would greatly decrease their risk. And the FDA did create a warning in 2016 about this risk. They then in 2017 came back to remind folks that we shouldn't withhold people from medication for addiction treatment, so methadone or buprenorphine, because they're on a benzo, because it's still safer for them to be on those medications than be illicitly using opioids, but it does increase the risk. Next slide. And then invite you all to check out our work group page on the Colorado Consortium. We have created some initial brief guidances. They're about 2 to 4 pages each, along with a much longer, almost as long list of references for those of you looking for more references. One talking about peer support for individuals, one about safe prescribing, as well as with the Benzodiazepine Information Coalition, we created a informed consent, a safe deprescribing guidance as well. And as has been mentioned, these are the other groups which many of our members are part of, and would recommend you go to their websites to look for a variety of resources and supports. So please Google them. Okay, next slide. And then finally, for those that are interested, I would really welcome you all to join us in the work we're doing. So we meet virtually the first Tuesday of the month from 12 to 1, and you can email the consortium to get on the work group list. Currently, so our work in the last year, we're creating those guidances. The next year, We are waiting for official clearance that the funding has come through, but we're developing a peer support curriculum specific to benzodiazepine peer support for individuals harmed by benzodiazepines, with the hope to add it to existing peer recovery, peer specialist education. And then also providing through funding from one of the recent legislative bills, creating a benzodiazepine provider education curriculum with our provider education group. And finally, in the next 5 years, would love to get more funding and develop research to really look at how to study different protocols for deprescribing and figure out how to best support patients that are going through this and what works for which individuals. Next slide. And then the rest of the slides have many resources and references. And I believe, Jamie, will these slides be posted afterwards, or you might have already said this?
The recording will be available online.
Okay, great.
So you can see the recording, but I don't believe that the slides themselves will be posted.
Okay. We can probably make a PDF if someone really wants them, and maybe put them on our work group page later. We can discuss. Okay, thank you all so much. And without further ado, we have our great original group member, John Staight. And I think we've figured out, he's joining us from up in
Yeah, I think he's
in the
back online,
mountains.
Alexis. So we're going to pop over to him and give it a try again here. So our next speaker up is John Staight. John Staight has been a patient advocate who began experiencing unexplained ill health and cognitive impairments in 2013. Over the next 5 years, he sought answers for his ever worsening health, which culminated in a 2-week consult at the Mayo Clinic's neurology department in 2017. He received several misdiagnoses along the way, including unnecessary and unhelpful medical treatments for those conditions. Through his own online research, John finally discovered he was suffering from benzodiazepine tolerance and withdrawal. He is currently in the midst of a difficult multi-year benzodiazepine and antidepressant taper. John is a founding member of the Colorado Consortium's Benzodiazepine Action Work Group, and he worked professionally as an open space manager for a local government until 2020, when his withdrawal symptoms became too severe to continue working. He now lives in Eagle County with his wife and 2 young children. So I'm going to pass it off now to John. John, it's all yours.
Hang on just a second. All right, well, I'm going to kind of fast forward through some of my presentation here because of the technical difficulties. But my objective here is to illustrate just how dangerous the medical journey can sometimes be for withdrawal sufferers, and also to give a little glimpse into what tapering is like and the accompanying brain injury symptoms. A little bit about me. I've lived here in Colorado for 22 years. I'm a UCLA graduate, married for 21 years. I have 2 young kids, ages 5 and 7, who are my world. And I was prescribed Xanax in my late teens by a psychiatrist when I was having a lot of anxiety around kind of my freshman year in college and transitioning from high school to college. And that started me down a decades-long prescription road of being prescribed Xanax. I was a very compliant patient. I really trusted my doctors who prescribed me Xanax. I always took it exactly as prescribed. And the only danger I was ever told was don't ever stop taking your Xanax suddenly because you might have a seizure. And that bit of information, I think, made me an I always had my Xanax with me. I was always diligent to not run out. In retrospect, I think I could have benefited from running out. It would have been a wake-up call. Fast forward to 2012, 2013, I was still taking 3 milligrams of Xanax. Over the years, I'd also been prescribed antidepressants. I'd never had a panic attack or a depressive episode before I was 18 years old. I mean, before I was put on a benzo. In 2013, my physical health started to decline. I started to have heart palpitations that were not panic attack related, muscle twitches and jerks, severe fatigue, a lot of the physical symptoms that Nicole had mentioned. And that led me to seeing specialists to try to figure out what was going on with me. I'd always been a pretty healthy guy. I was very active in the outdoors, and I started seeing cardiologists and sleep specialists and rheumatologists for these bizarre symptoms that my symptom list just kept growing and growing with all these bizarre symptoms. But the most disabling symptom by far was the intense brain fog I started to have. Started to have difficulty understanding documents at work and responding to emails and organizing my day. And finally, in 2016, I was referred to a neurologist. And the neurologist did several MRIs. And at one point during this, I had one episode where I was so lost in my own house that my wife had thought I had had a stroke. And she had taken me to the ER because she was pretty convinced I had had a stroke. And of course, MRIs were done. They all came back normal. But in 2016, I at least had a neurologist do a neuropsychological test, which is a cognitive functioning test. And the results of those tests, and really that was the only medical test that was done on me that ever showed that there was something wrong with me. And the results of that test showed that my verbal reasoning and comprehension skills were in the 98th percentile, but things like my short-term memory and processing speed were in the 9th percentile and the 4th percentile. And the clinician summarized the results of my test as follows. This is a quote. The results of the cognitive testing suggest that Mr. Staight is an individual with superior verbal reasoning skills with an academic and vocational background that would suggest a uniform high level of general reasoning ability. The testing demonstrates a significant decline on nonverbal reasoning ability and an even more profound decline in the area of mental processing speed. And in addition, he displays weakness in his ability to concentrate and maintain focus and a significant weakness in memory functioning. And the diagnosis was neurocognitive disorder of uncertain etiology. That led to more MRIs that gave no answers. And finally, at one point, my wife and I were convinced that I was dying of something that had not been diagnosed. And all this time, I was checking in with my prescribing psychiatrist who was writing the prescriptions for my Xanax. And I'd always ask him, and I asked this of every doctor I saw, all the specialists, and I saw 30 doctors by the fall of 2017. I always said, could it be something to do with my meds? I'd always list all the meds that I was on, and the answer was always, no, it's not your meds. And I told my psychiatrist, I said, look, at this point, I just want to rule out variables. Why don't you taper me off of some of these things and see if that could be a possibility? And looking back on it, from 2013, he had been reducing my Xanax by 0.5 milligram every few months. So he was sending me deeper and deeper into benzo withdrawal, but not recognizing the symptoms of benzo withdrawal. In fact, it was my psychiatrist who was saying, yeah, maybe you need to go to the Mayo Clinic. You should really, there's something neurological going on with you. So that kind of diverted my attention away from the meds being the problem, because all the experts were not saying the meds were the problem. So by the fall of 2017, I did get a referral to the Mayo Clinic, went there for a 2-week workup in Minnesota. And after 2 weeks, the Mayo Clinic's diagnosis was suspected autoimmune encephalitis. And for that diagnosis, I got 8 weeks of IV steroid infusions at my local cancer clinic. Didn't feel any better. So then I got 8 more weeks of infusions with IBAWG blood products. Still didn't feel any better. And at that point, the Mayo neurologist said that perhaps I had early onset dementia, or maybe even a genetic form of ALS, because my sister had died from ALS, which of course scared the wits out of me. But then everything changed in February, on a day in February 2018, when one morning I woke up and all my symptoms were off the charts. And for the first time in my life, I felt actively suicidal. I left the house in a rage. I drove up a dirt road. I started hiking up the side of a hill that had a cliff on the other side, and I was ready to jump. And the only thing that stopped me was thoughts of my young son and my daughter. And I turned around and I went home, and my wife said, I walked in the door, my wife panicked, said, John, what happened? What on earth happened? And I said, it's gotta be the Valium. I was on Valium at this point. And that week, my doctor had me reduce the Valium by 1 milligram. I'd gone from 12 milligrams of Valium to 11. And that flipped the switch and made me suicidal. From that point on, I luckily found online resources like the Ashton Manual, the Benzodiazepine Information Coalition's website, which was a lifesaver. And I couldn't believe it. I couldn't believe, after 5 years of being sick, after seeing so many specialists, that I was suffering from withdrawal from one of the most commonly prescribed medications that's been around for 60 years. So at that point, I really lost most all faith in the medical system and turned to the online patient support groups for my support from that point forward. Now I realize that I can only tolerate reducing my Valium by 2.5% per month, which is very slow. So it's going to take me years more tapering to come off. And I've also found that antidepressants are problematic to come off of. So that's going to take me quite some time to taper off of. And the limit on that speed, if I go any faster than that, if I go too fast, I go into a state of I call it chemical terror. It's like having a panic attack that does not end for hours or days. It's an unbearable state of being. And I've had doctors say, oh, well, you can go faster than that. You can go much faster. No, I can't. My body cannot tolerate a faster taper than that. So anyways, I guess I'll go ahead and end there so we have time for questions. But yeah, I will mention there's a lot of the cognitive impairment has caused a lot of problems with things as simple as reading a book to my kids. I can read them a book, I can read the words, but I can't comprehend a children's book. I can't do the multitasking of comprehending and reading at the same time. I can't do Legos with my son. I can't assemble bikes or bunk beds. I only drive very short distances here in my local community because I don't feel well enough to drive any further. Any amount of stress is unbearable. And of course, there's been a lot of losses in all of this, but I do consider myself very lucky to be alive. So thanks. Dee, over to you.
Yeah, thanks, John. That's a great story to share. Thank you so much for your powerful message, and for everybody, for Dr. Ritvo, for John, for Nicole, for speaking today. We do have some questions, and what we're going to do is we're going to take some of those now. I know we ran a little late, I think, because of some of our technical complications. It kind of delayed us some, but we can run a little over. Just so everybody knows, there is a stop at 9:45 Mountain Time, and then it's a 15-minute break before the next session starts for those who are going to the general session starting at 10, but we can run a little over. So we're going to do some Q&A, if it's okay with the other presenters, and just kind of carry on for a bit and try to get to some of these questions. I've been going through, Jamie and I both have been going through the chat and reading this great stuff and conversations in the chat and seeing a lot of old familiar faces in there. It's been great. But here's some questions that came out. One came from Doreen, actually, which was with the Alliance and one of our members of the Action Work Group. She says, is there any combined efforts to get system-wide changes in BZD prescribing among providers? Alexis, I was wondering if this is one that you might be able to respond to for us.
Sure, and Nicole might have something to add too. And I think this is multifaceted. I know through the Alliance for Benzodiazepine Best Practices and the Benzodiazepine Information Coalition have both been working on this. The Alliance was pretty instrumental in getting that FDA black box warning. And I know they're working on some other prescriber education approaches. However, I think there's a lot I've given kind of a different version of this talk before, talking about how we should take a lot of the knowledge and approach we used with the prescription opioid epidemic and apply this to benzodiazepines. And I think we really need to try as much on a more local level to change the culture and attitude of and knowledge of prescribers with these individual stories and resources. And because I have young children, just like my young children don't like to be told what to do. As adults, we don't like to be told what to do or told that what we are doing or know is wrong. So I think we have to think about how you do this in a similar to how you approach the taper as a team and in a non-judgmental, non-shaming way, but to provide a different set of knowledge. For a long time, there was a while that everyone was being told opioids were safe as long as it was for pain. And benzos came along and we thought they were safer than barbiturates. So I think it does need to be kind of multifaceted approach. And the more we can replicate what is working on, a local and state level, I think will be the most successful.
Nicole, did you have anything else to add to that?
Alexis, did you talk about the bill in Colorado?
Oh yeah, so I can. I think I briefly mentioned we got some money for provider education, but thank you, Nicole. So we were successful, and actually, only the second year it went up in front of the legislation, House Bill 1276, to get added to prescribing that there will be an initial limit for anyone that has not had a benzodiazepine prescription in the last 12 months, that when they are started on one, there will have to be a limit on how much they're provided. The medical DORA with medical licensing will determine what that limitation initially is. But again, to try to really impart on prescribers and patients what the risks of taking these long terms are. So thank you, Nicole, for that reminder.
And also want to mention too, of course, we said a little bit as we're working on some of the legislation off of the work done in Massachusetts too, and to Sonia Stiblo and for those people that have been working out there and been working on their efforts for so long too. It's been a group effort amongst all the different groups out there. So I just want to give a little shout out to them and let them know how much they did. So anyway, so the next question I have here is, do all states, this is from Joanne, do all states now have the black box warning? This is federal, it's FDA designated. So yes, it goes out nationally. So all states would now have the black box warning. It's from the FDA and you can find it online via link. In fact, if one of us maybe can post it up here on the chat, maybe we can have that. Alexis, you agree with that? Or
yeah, I'll put it in there.
Great, thanks. I don't know if there's anything else on that one. Nicole or John?
I can just chime in for a second. This is Bernie Silvernail. While the black box warning is there for most of the medications, when you do just a simple Google search for it, you get the old one, which does not include the current warnings about long-term use. That's the first one that comes up. It's about number 9 or 10 down on the list on several of the medications before you actually get to the updated version. I have no idea why that's the case.
That is a great point. You have to specify because the previous one was related to in concurrent use with opioids. And so that one may come up first. And the one we're looking for is the one that's more effective with long-term use. I think my Google has become catered to me, so it automatically brings that one up anymore. But I think that's a great point. And for those who don't know, Bernie is actually with the Alliance for Benzodiazepine Best Practices, one of our outstanding organizations. So thanks, Bernie, for the extra info. So make sure you're pulling up the right FDA warning there. So. Let's go into another one here. This one's from Brandy. I think it's Brandy is pronouncing. If I'm not correct, I apologize. Can you share your BZ taper protocol used in practice? I find there's not a lot of good guidance on how to describe in primary care. And this is a question I get all the time through the podcast, and one I can't answer, of course, being not a medical professional. And it may not be the case for Nicole or Alexis either, but I'd like to at least throw it out there to the two of them.
Yeah, I mean, I will put in the link the deprescribing or tapering guidance that's now posted on our work group webpage, as well as the information that both BIC and Alliance has. You know, I think if we can drive anything home, it's that for most patients, there's not a one size fits all, and you have to work with each patient to figure out what works for them. You know, the day we figure out what makes some people's body and nervous system so sensitive to these medications will certainly be helpful, but we need more funding and more research. So some individuals can tolerate a much faster taper, and I'm sometimes surprised, but I think we often do more harm by trying to say, oh, well, our general knowledge from opioids or our general knowledge from alcohol, which acts on a similar system but not the same, is that we can, you know, taper the benzos by this much, and that's where you can induce some real harm. So I'll put some of the information we do have about different approaches here, though.
Nicole, you have anything to add to that?
Muted. I just put in the chat a link to the Ashton manual, and then also a link to the Withdrawal project, which I co-founded. The Ashton manual is a great guide, but again, like Alexis just said, it should be tailored to each individual. Some of the schedules she has in there are too fast for people. And then the Withdrawal project, we have a companion guide for tapering. It was basically put together using all of the anecdotal experiences of the lay people withdrawal community who are actually the ones doing this themselves. And so we took all of the knowledge from those communities and we made a companion guide for people to help teach all the different ways that people can use to get off of not just benzodiazepines, but psychiatric medications in general. So yeah. It doesn't tell you how to specifically schedules how to do it, but it does give you all of the ways in which people do taper. So you can learn from it and then choose for yourself which one you want to try, you know, with working with your physician.
Great. Thanks, Nicole. Yeah. And one thing too on that, just to mention, is I get a lot of calls on that through the podcast. And one thing I always try to emphasize is to please work with your primary care provider and to work with a physician. If you're going to be withdrawing, I know this is something that a lot of people struggle with because for so many, they've gone back to the provider and the provider is not wanting them to withdraw or is not helping them or is, you know, dismissing them. And maybe they need to find some new provider or something, but it is important, I believe, to have a provider who at least will work with you. They don't have to be benzo wise, but somebody who can work with you and help you with the taper, not just with, of course, the represcribing of the medication as you taper, but also to make sure that, I mean, you have a lot of symptoms along the way and you need a physician who kind of knows what you're going through, you can go to and get tested and make sure, you know, answer these kind of questions. So it's just something else to make sure that, you know, if you can, it's good to have somebody who's a physician or medical professional work with you on this. They come in real handy. So let's see here. This one is from Carolyn. She says, can you possibly share the references for the study showing 10 to 44% of patients having long-term effects? I think, Alexis, was that your slide or was that?
Both Nicole and I put the references in the chat. It was the Ashton.
And we're going to try to provide these as a PDF online too, right? Later, or I know we're going to release
we can ask about making them, as long as all the presenters agree, a PDF and putting it on our work group page.
Okay, yeah, we're going to try to do that as long as the presenters agree. We'll try to make all the slides here available and put a link for that on our page. So great, thanks. Here's a question from Jamie. Actually, Jamie, who's been running this. So Jamie posted this. I don't know if it came from another person or not. Does benzo withdrawal weaken your immune system? I don't know if any of three of you would like to pipe in on that one.
It would not shock me if it probably does. I don't know that we know how. I know that we have our walking library, Dr. Stephen Wright, is in the audience. I don't know if he knows. I know he just
can we tap him while he's here?
I know how he put in the chat another reference about how chronic administration of benzos leads to unexplained chronic illness. I will say, one parallel I'm also drawing, in addition to, we need to apply what we've learned from the opioid epidemic, is that I think thinking about, the long COVID syndrome that a lot of individuals are experiencing, that is such a myriad of symptoms, and some seem related and some seem totally unrelated to COVID and doesn't correspond to how severe COVID someone had. And I think there's a lot of parallels that we can maybe draw, that, it's not always what we expect. There's so much knowledge we lack out there about how some of these medications and each individual's complex neurophysiology work.
Great. I see Steve did raise his hand. So Steve, do you want to pipe in on this one?
I can. It's just that there really is no information on the immune effects of benzodiazepines, at least in a review that I did maybe about a year ago. And sadly, like many other areas related to benzodiazepines, it just hasn't been investigated. So we're stuck with that for now. Any of you want to study that? Let's do it.
Great idea. One question that came from Carrie was, and just so everybody knows, it is 9:52. We're going to take one more question and then probably close this out. But if you wanted a break before the next session, probably now's a good time. So if you need to drop off, that's great. Has anyone started a class action lawsuit for those of us who have suffered so much and have lost wages? I do know that JC did provide some answers here from BIC on the chat room. And because I think they have something on their site that feeds that, but I didn't know if other panelists had some information on that or not.
Sorry, go ahead, Nicole.
I was just going to say there was a class action lawsuit in the UK back in the 80s, I believe it was, or the early 90s. I can't remember. So you can research that and see it didn't really go anywhere. I think they ran out of money. So nothing in the United States, though. Alexis?
Yeah, I was going to say, I saw someone else mention part of the issue is these medications have been generic for a long time. So it's harder to know who exactly you hold accountable. The other issue, as we've all pointed out, is the research. I mean, needing more comprehensive research, and the fact that the symptoms that individuals experience can be so broad. And I think the argument would be, while temporarily and from just the sheer number, we see that it's linked back to their prescribed benzodiazepine and also stopping it, that probably they would argue it's hard to truly prove causality.
Yeah, I agree. In fact, when I was researching my book, we came across, as you mentioned, Nicole, the study in the 80s had, I believe, over 14,000 patients on that class action one, but it did wind up with never reached a verdict. There were some problems with the trial and stuff. Some other people have had some success. Individuals, Ray Nimmo, who's the founder of benzo.org.uk, had some success. And also Lord Montague actually received a large settlement from the UK based on his usage. But those are individual. I don't know of any really specific class action that's taken place. But I also know, like you said, Alexis, it's very hard to prove. And that's part of the problems we face. So anything else, last words from the speakers, and then we can close this out. John, are you still on? Do you have any last words?
No, I guess the only thing that I forgot to mention is that, my benzo withdrawal, one of my losses is I'm no longer able to work. I did have to resign from a job that I really loved about a year ago in order to continue tapering. And to survive, and especially can't make a living while they're trying to taper off of these drugs.
I hear you. Nicole, you have anything last words here before we close out?
No, I'm okay. Thank you. I guess the only thing is we did have some success at BIC with people reporting their injury to the FDA. So I think anyone, including clinicians and patients who were harmed by these medications, should file a report. I think only something like 1% of people report drug harms in general. So it's important to report your injury there.
And can they learn how to do that from BIC site?
Yeah, we do have, we can put something in the chat.
Okay, great. Thanks, Nicole.
Thanks, everyone.
Sorry, go ahead. That's it. Alexis, last words for you?
No, thank you all for being here, and thank you to Nicole and John for sharing your personal stories, and hopefully we can slowly turn the tide, and we invite all of you to join our work group.
Thanks. This has been great. I want to thank everybody for joining us. I want to thank the Colorado Consortium for Prescription Drug Abuse Prevention for inviting us to join them as a benzodiazepine work group and to provide this presentation. I want to thank Jamie Feld especially for running all the different work behind the scenes and getting little credit. So thank you, Jamie. And just thanks to everybody. This has been great. We will try to get the video up online and also get some of the slides here online so we have more references. If you want more information on us, you saw the links in the chat room. And also reach out to our organizations we work with, Benzodiazepine Information Coalition and the Alliance for Benzodiazepine Best Practices. Great resources. Please check them out if you're looking for information. I just want to thank everybody and thank you all for joining us.
Thanks, everyone. And in the chat is how to access the annual meeting. We hope that you stick around for that. It will start at 10 a.m. Even if you're not familiar with the consortium, we'd love to have you join. And then also, as Dee mentioned, the information about the work group page is in the link, and also how to get involved. So we hope you all stay involved in this work. Thank you again.